My name is Dr. Rafi Kevorkian. I would like to talk to you about weight loss in the elderly today. As you can see in slide 2, a take-home message is that weight loss leads to death. In studies published by Pamick and Reynolds in the top part of the slide, showing that regardless of the patient's BMI, weight loss leads to death. In the bottom study, showed that women in study published by the group that they had a greater mortality when they had weight loss due to greater debility. One of the main complications of weight loss are falls and hip fractures due to loss of muscle bulk that typically occurs in the elderly. And as you can see, whether it was voluntary or involuntary weight loss, there was a greater incidence of falls and hip fractures in patients. Many seniors feel that they're overweight and that they should diet, and as a result, there's a potential harm in weight loss in certain patients. In this next slide is listed the survival curve when the elderly patients lose weight. 1,000 patients had been followed after they initially had weight loss. In the black color, patients continued losing weight, and as such they had a 30% mortality rate after 6 months. In the green color, these were patients that stopped losing weight, but they didn't gain any weight, and they had a 20% mortality rate after 6 months. And then in the red color, these are patients that gained over 5% of their weight, but despite that, they still had a 10% mortality rate after 6 months. As you can see, effects of protein energy undernutrition can lead to pressure ulcers, weakening of the immune system, higher incidence of infections, falls that can lead to hip fractures due to muscle bulk loss, confusion, delirium, and cognitive impairment, anemia, fatigue, edema, and increased mortality. These are all associations that have been seen with malnutrition in the elderly. Interestingly, the effects on the immune system as seen in malnutrition are similar to what we would see with aging. There's a senescence or a weakening of the immune system that's seen with aging, and it's comparable to what you see with protein calorie undernutrition, such as a decrease in the number of T cells, interleukin-2 that helps stimulate the immune system and cause fever, and the overall response and the effectiveness of the immune system in killing foreign microbes. There are some physiological changes seen with aging and body fat distribution. We tend to be lean in both male and females in our young 20s, and as we age into our 40s and 50s, there's an increased distribution of fat and less leanness. And then, as you can see, in upper 80s, it reduces again to where there's less fat and patient is more lean. Benefits and functions of fat: it's to help with storage and for energy production. It helps keep us warm, and it helps cushion and protect our organs on the inside. As anything else in life, food is key to survival. In this slide shows the caloric intake throughout the aging process in males and females, and it's shown that elderly patients tend to eat less calories as compared to their younger cohorts. You can see a typical male in their 20s may eat about 2,000 calories, whereas a senior in their 80s will eat about 40% less of that amount, and that's also seen in women. In this next slide that was done in a cohort of inner city elderly patients in the St. Louis metropolitan area, there was a high incidence of depression as tested out by the Geriatric Depression Scale, and it was shown that when an individual had a companion to help socialize with them during a meal, that there was a increase in caloric intake, and there was weight gain associated with increased socialization in the elderly patient. Some other changes that are seen with aging, effects on taste and smell have been noted, where there's a decrease in odor identification, and also effects on taste threshold and quality of tasting of certain foods, which have been shown to decrease the amount of food that the elderly patient may eat. Set of slides, we're going to discuss a condition called the anorexia of aging that has been described in the literature. In this slide you notice comparisons in the older and younger patient in terms of how soon they become full or become satiated. And as you can see in the blue line, after a meal, the sensation of fullness occurs earlier and sooner than in a young patient. The other insert shows that there's also a change in the gastric emptying in comparison between younger and older patients, and also the sensation of fullness that's also seen that occurs earlier in younger as opposed to older patients. Next slide, this looks at the fullness and satiation in the antral area. The left insert is in younger patients and the right insert is in older patients. And as you can see, there's a greater stretching as seen in the antral area in the older patient that leads to earlier satiety. So to recap in this slide, notice that there's a change in the adaptive relaxation of the gut when nitric oxide is released, which leads to a slower emptying of the gut, which leads to increased antral filling and alteration in the antral stretch, which leads to earlier fullness in the elderly patient. Next slide, studies were performed in which nutrients such as glucose and fat were inserted intraduodenally, and it looked at the desire to eat, hunger, and fullness in younger and older patients. As you can see, with the introduction of glucose, there was no alteration in fullness, whereas the introduction of lipids, there was a earlier sensation of fullness in the elderly patient. Next slide, you can see looked at the effects of intraduodenal infusion of nutrients such as glucose and lipids on common GI hormones such as CCK, GLP-1, and PYY. And as you can see in the elderly patient on the right hand side, with the infusion of lipids, that there were greater levels of cholecystokinin and GLP-1 in the elderly patient. This next slide looked at the total caloric intake of food while there was an infusion of saline, cholecystokinin at 2 different dosages in 12 younger and older subjects. And as you can see, with the higher dosages of cholecystokinin, there was a lesser intake of food in terms of the amount of calories ingested in the older patients compared to the younger patient, which is statistically significant. In this slide, this looks at the levels and longitudinal levels as seen with aging, and starting at the age of 31, there's a 1 to 2% decline in hormone levels of the testosterone in males, and that continues throughout the lifespan. This next slide, this looks at the effects of androgen supplementation in hypogonadal men that had low testosterone levels on lean body mass and fat mass. And on the left-hand side, you can see that patients that received testosterone supplementation became leaner over a 12-month period compared to those that had placebo. And there was also a change in and decrease in percent fat mass in the patients that received testosterone versus placebo. The other changes that are seen with aging in terms of testosterone and leptin levels, with aging, as there's a decrease in testosterone levels in the serum, there's a rise in the leptin level, which then causes a drop in the neuropeptide Y and the nitric oxide synthase release in the hypothalamus, which leads to less food intake. Summarize with the syndrome of the physiologic anorexia of aging. There's a decrease in smell, there's a decrease in taste, there's an increase in fat mass, there's a decrease in the testosterone levels, which affect leptin levels and TNF alpha levels that all act in the brain and lead to decreased food intake. There's also alterations in the gut that occur with increased cholecystokinin release and levels, with a change in the adaptive relaxation of the gut that leads to an earlier antral stretch, which leads to a decrease in the rate of gastric emptying and an earlier sensation of fullness. This slide looks at the causes of malnutrition that are typically seen in the outpatient setting, and the most common cause in the elderly patient was 30%, although that was also common in the younger patients. Other causes included malignancies, issues with swallowing, and chronic pain. The nursing home setting study done by Morley and published in JAGS looked at the common causes of weight loss, and as you can see, depression is the most common cause, and length of stay less than 6 months or greater than 6 months. Other common causes in the nursing home setting include wandering in the demented patients, anorexia and alterations in taste caused by medications, the presence of psychotropic medications, dehydration caused by diuretics. This study looked at the types of diets that are given to non-insulin dependent diabetic patients, and it looked at regular diet and diet with concentrated sweets, and it showed that there was no difference in the hemoglobin A1C in these cohorts of patients in the nursing home. This next slide is to remind you that certain medications have side effects of anorexia, and this is the effects of digoxin toxicity, as you can see with the yellow halos that is commonly causes anorexia. This slide, this is to remind you that pain, which is common in a fair number of our patients, that's not typically assessed for, is also a common cause of anorexia and weight loss in the elderly patient. So to recap, in this slide we're going to review the causes of weight loss. This mnemonic called Meals on Wheels has been published in the literature, and a lot of times when I do have an elderly patient that's losing weight, I will sit down with the mnemonic and do a checklist and evaluate potential causes that I could find and reverse to help improve weight loss in my patient. The M is for medications. There are a multitude of medications that cause anorexia. Many of them are cardiac drugs such as digoxin, amiodarone, ACE inhibitors alter taste, what we call dyschezia. Metformin is a common cause of appetite suppression. Topamax is commonly used for weight loss, can cause appetite suppression. Many of the antidepressants can cause nausea and appetite suppression, such as Prozac. If you're uncertain if a potential drug is causing appetite suppression, all you need to do is look it up in the PDR, and if it looks like it can cause appetite suppression, then that you should give consideration to stop that medication. As we mentioned and saw, depression is a common cause of weight loss in the outpatient and the nursing home setting. It needs to be assessed for in every patient that's losing weight, and antidepressants should be started if that's the cause of the weight loss. The A is for multitude of conditions such as elder abuse, anorexia tardiva, and alcoholism. The L is for late life paranoia. You will come across many demented patients that will feel that their food is poisoned and they will not eat. You will need to treat the delusions with either acetylcholinesterase inhibitors to help improve memory, or if there's delirium that's being caused by an infection or some other cause of delirium, then that has to be treated to help stop the late life paranoia. Many seniors will have swallowing difficulties. Commonly you will see dysphagia in patients with strokes, Parkinson's disease, debility, dementia, and diabetes. You will need to have that evaluated with a modified barium swallow and or a speech therapy evaluation, and then the diet has to be adjusted accordingly. Many patients have ill-fitting dentures, bad teeth that will cause them not to want to eat. The N is for nosocomial infections and poverty. Meals on Wheels is commonly available for patients that will give them one extra meal a day. Medicaid will help pay for supplements under an exception. The W is for wandering and demented patients, where they can extend large amounts of energy as they wander throughout the nursing home. The H is for hyperthyroidism, hypercalcemia, and hypoadrenalism. The E is for enteric problems such as malabsorption that can commonly be seen with small bowel bacterial overgrowth. Next, the E is for eating problems. Many patients that have tremors may have occupational therapy provide them with a gated or a weighted utensil. Patients with strokes may have utensils that will help them to cut a meal, for example. The L is for the low salt, low cholesterol diet that's commonly prescribed in the hospital setting in heart disease or heart failure patients or diabetic patients. And as we saw, a regular diet in diabetic patients, did not alter the hemoglobin A1C compared to when there was a therapeutic diet. And last but not least, the S is for shopping and meal preparation issues, where sometimes family members will have to help provide meals for patients, and if there's a lot of pain after meals, the patient has to be assessed for gallstones. So in the meantime, once you've assessed for the cause of the weight loss, treatment has to be instituted, and the first line treatment is to start nutritional supplements. In this study, there was a Cochrane database that looked at multitude of trials with large numbers of patients, and it showed that supplements caused weight gain that also led to mortality and a decrease in length of stay. So the key point here is to give the patient more food, and as such, then, if the patient would like to have double portions, give them double portions. Have a dietitian assess for food preferences and ethnic preferences for our elderly patients. With the supplements, timing of the supplements is key. It is better to be given in between meals as opposed to with meals, because they tend to cause fullness when given with meals. And also, if the patient requires help feeding, a study have shown that if patients are fed, they will eat more food than if they're left alone to eat on their own. What about medications to help improve appetite? We call those orexigenic agents or appetite stimulants. Historically, there's medication called cyproheptadine that has not been shown to improve appetite. There's also hormonal agents, cannabinoids, and anabolic agents. Steroids have not been shown to statistically improve food intake and caloric intakes that leads to weight gain in the elderly patients. Ghrelin has been used for the anorexia of aging that has shown increased food intake, but it has not been statistically significant in causing weight gain. Dronabinol or Marinol has been studied in a multitude of settings, specifically in AIDS patients, that has been shown to help improve appetite intake. It's also been shown in demented patients who had weight loss that it also improved appetite intake. Typical dosing for dronabinol is 2.5 milligrams at bedtime, followed by twice daily with meals. The main side effect has been hallucinations. Unfortunately, dronabinol has Class C evidence and is not commonly used in the elderly patients. Studies have been performed comparing dronabinol and Megace separately in combination, and it's been shown that dronabinol in combination with Megace is no better than Megace alone. The appetite improvement for Megace, as you can see, is statistically significant. Megestrol or Megace has had a multitude of studies done in cancer patients that showed increased in appetite, weight gain, and quality of life. It's also been shown and has been given to AIDS patients, which also showed an increase in weight gain. Besides, megestrol acetate has been shown to maintain appetite and weight gain beyond the active treatment period of 3 months for up to 6 months. Also, through laboratory studies, shown that it increases albumin levels, improves BMI, improves anemia, and also increases the lymphocyte count in these patients. This is showing you the effects of cytokines and its association and cause of frailty. Cytokines are elevated in a multitude of illnesses such as congestive heart failure, chronic kidney disease, liver disease, AIDS, malignancies, and typically when these interleukins and tumor necrosis factor levels are elevated, they can cause anemia of chronic disease, they can cause frailty, which leads to increased mortality, they cause anorexia, they can cause bone loss and osteoporosis, they can cause a reduction in the synthesis of albumin, they can cause protein loss of the kidneys, they can cause atherosclerosis of the heart that can lead to heart attacks and mortality. A major detriment from cytokines is cachexia, as seen in malignancies where patients can lose 30, 40, 50 pounds within a short duration of several months. That can lead to frailty and death. Megace has been shown to affect these cytokine levels, which can lead to improvement in weight, fat mass, and free fat mass after a 3 months duration of treatment. Side effects for megestrol include potential for elevating sugars, adrenal suppression, which is a very rare condition, hypogonadism in men, and there's a 1%, 2% incidence of DVTs. Dosing for Megace, which is the standard dose, is 800 milligrams. It comes in the 40 milligrams for 1 ml suspension, and you would give 20 cc's once daily, preferably with food. Because it is a steroid, it is better absorbed with meals. You should avoid medication in patients that already have an existing DVT or at high risk for DVT. Historically, Megace has had Class A evidence, but in the last 1 to 2 years, a large meta-analysis showed that patients that took Megace versus those that didn't had a higher mortality rate. So you should use it with caution in your frail, dying patients that have a life expectancy less than 1 year. So you have to have experience prescribing the medication and use it wisely in patients that have a potential for recovery from a major illness. Roughly 10 years ago, the Council on Nutrition made some recommendations in the management of patients with weight loss. They made a recommendation to use appetite stimulants when there was no obvious cause of weight loss present, that was reversible. To treat with anabolic steroids, preferably with testosterone, for muscle loss, although that's not a common usage anymore. To help give megestrol to patients to help improve appetite, but you should use it with caution in our frail, debilitated patients that have a life expectancy less than 1 year. That it should only be given for 3 months and not longer. Mirtazapine or Remeron should only be used in patients who are losing weight if they are depressed, and you may consider electric shock treatment if they are severely depressed. Dronabinol or Marinol is also an option, but it's fraught with side effects, and it may be a good end-of-life care medication.